Alright y'all, so I've been working to put these videos together for you so you have something to do over the spring break to help get caught up for this debacle on the HLC campus, meaning that I've put more time into putting these videos together than you probably have into studying. So remember, there's going to be a quiz over these two videos when we get back to class next week. If this doesn't apply to you and I'm using this video at another time and you don't know what I'm talking about, then don't pay attention to it. There are two parts to the videos that we're going to be making. So there's going to be two separate videos going over blood vessels. The first video is going to be a lab discussion in which we go over coronary circulation, then systemic circulation, talking about arteries and veins and how you're going to have to give me things on an exam. The second video is going to discuss our special circulations, notably hepatic portal circulation, the circle of Willis, and fetal circulation. And you have a handout that corresponds to these two videos, so make sure while you're going through these videos to think about the questions on your handout and really think about what I'm presenting in the video, notably things like the images. So if you go to your blood vessels lab, and that's what I have in front of me right now, this blood vessels lab was put together by the department. And if you look at the first set of objectives within the blood vessel lab, it says blood vessel models. So within the course of the previous lecture, we had talked about the anatomical and histological differences between an artery and a vein and why they're there. The models that we are going to use in lab for either an artery or a vein, right, if we're talking about them from a histological perspective, is this guy right here. This is the model that's found on every ACC campus, and therefore I use it just in case I go from one campus to another that doesn't have one model but does have this model. It is a universal model at ACC. And when you look at it, it's pretty easy to identify the artery and the vein. So, or the system of veins, because remember, if we bring blood to a part of the body, we have to take it back. And remember that pipe analogy I talked about the first time around. If you bring water somewhere, you have to get it out of there. So, arteries carry blood away from the heart, and as we know, arteries are much thicker than veins and tend to hold their shape under microscopic image. We have the tunica interna, aka the tunica intima, which has our endothelial layer, that's that single layer simple squamous epithelium, the basement membrane, and the internal elastic lamina. Remember, muscular arteries have this elastic lamina. It's not that veins don't have an elastic lamina, but arteries tend to have more elastic tissue in them in general because they have to be able to distend and then recoil in response to ventricular systole and ventricular diastole. Now, if you look at the tunica media of an artery, you'll notice that the smooth muscle is much thicker. That means that it's capable of vasoconstricting and vasodilating to a much greater degree than veins are, so it plays a more important role, or arteries play a more important role in controlling the distribution of blood in the body, and then arterioles are really important in that respect. We have the external elastic lamina, so we know we're looking at a muscular artery right here, and we'll talk about the difference between a muscular and elastic artery in just a little bit. And then we have the tunica externa, aka the tunica adventitia, which is just a layer of connective tissue that stabilizes all these structures. Now, within this, you also have to know the vasa vasorum, which are essentially the blood vessels that feed the blood vessels themselves, and that's what's running up here that you can see on this model. Veins have all these same things, but the tunica media is much thinner because it doesn't actually have to accommodate for those high pressure fluctuations, and it's not controlling the distribution of blood in the body quite to the degree that arteries are. And because veins are low pressure systems, you clearly see the valve here. So if I was to ask you the type of blood vessel or the type of blood vessel, I'd expect you to be able to give me anatomical justifications. Now, when you look at these blood vessels, either a vein or an artery under the microscope, you can see the tunica interna, aka the tunica intima, the tunica media, and the tunica externa, aka the tunica adventitia. But the big things that I want you to do, if I ask you a histological question, I'll essentially ask you, identify the type of vessel indicated by the pointer and give me a couple anatomical justifications for your answer. Arteries tend to hold their shape even under a histological image, because they have this big, thick tunica media, which is made of smooth muscle, which allows for vasoconstriction, vasodilation. Remember that the blood flowing through this artery is going to be high-pressured blood, whereas the blood flowing through the vein is going to be relatively low-pressured blood. If we look at what's locking these arteries and veins into place, you actually see that they're embedded within fat. So adipose tissue serves a multitude of functions within the body. The vein, on the other hand, has a much thinner tunica media, and the tunica adventitia won't be the focal point. The tunica media will. And if you look at there are some residual blood cells. And veins, if you look at them closely under microscopic image, tend not to keep their shape when you section them and plate them onto a slide. They tend to collapse because they don't have that big, thick layer of smooth muscle holding them open. So on an exam, if I said identify the type of vessel indicated by the pointer, this would be an artery. It's an artery because it has a nice thick tunica media, which is capable of lots of vasoconstriction, vasodilation. And what would be flowing through here is blood. The blood in here would be under relatively high pressure, while as you look at the vein, which has collapsed a little bit, veins typically transmit blood that's low pressure. It's a low pressure system, and that's why we do venous blood draws, because you're not going to get those fluctuations with ventricular systole and ventricular diastole. And the reason it's a vein is we don't see the valve, but we do see this really thin tunica media, and it's collapsed under the microscopic image. In addition to that, you can also see a little bit of residual blood in the vein itself from this image. So think about, again, when you're looking at the artery and vein slides, think about what I just mentioned about the histology that you have to know on an actual slide or a specimen. And I'm giving you these things because we've missed class this week, so you may want to pay really close attention to the way that I'm phrasing things. So, there are two different types of arteries. Elastic arteries, such as the aorta, that's kind of the quintessential example of an elastic artery. Their tunica media is perfused with elastic tissue, and that's when we were talking about elastic connective tissue when we were going over the different types of tissues in the body. And what you see here are elastic fibers just perfusing through this tunica media. And the large blood vessels have all those elastic fibers rather than the elastic lamina, because they really need to be able to withstand huge pressure changes. During ventricular systole, blood vessels such as the aorta and the major branches off the aorta, right, undergo massive distension, and then they have to recoil. And again, they play a particularly important role in maintaining blood pressure during ventricular diastole. As these elastic blood vessels start to branch to form smaller blood vessels, or the elastic arteries start to branch to form smaller arteries, those arteries become muscular arteries. And that's most of the arteries we're looking at in the body. They deliver blood to specific portions of the body. And this is where we're looking at the tunica intima with the internal and external elastic lamina, and we have this tunica media that's not quite as perfused with elastic fibers. It's predominantly smooth muscle. So I just kind of wanted to point that out. That's what it's talking about when it talks about an elastic versus a muscular artery. The elastic arteries are the big arteries like the aorta, and they need to have all that elastic tissue in the tunica media so they can expand and then recoil. Because they're subject to huge pressure fluctuations. As blood starts to move further away from the heart, as it moves through the elastic arteries to the muscular arteries, that blood pressure drops just a little bit. Those fluctuations decrease. So there still needs to be elastic properties to the tissue, but not quite to the same degree. And the aorta would be the only elastic artery I'd expect you to know. All the other arteries we're going to look at are muscular arteries. Now, when you think about the circulations that you need to know, even though this is on the previous lab from the heart, I want you to think about a model like this. I want you to actually go through and I want you to label something like this, because you're going to have coronary circulation on the exam. The heart itself needs blood. The cells of the heart, the contractile cardiac muscle cells, are really efficient at extracting oxygen from blood because they have this protein, this pigment similar to hemoglobin called myoglobin. So the heart itself needs a huge amount of blood, and blood flow to the heart is really important. So on the exam, the reason that we're bringing this up first with respect to systemic circulation is if you look at the ascending aorta, which is where the left ventricle pumps blood up and out through the aortic semilunar valve into the ascending aorta, the right coronary artery and left coronary artery branch directly off the ascending aorta. So what actually generates the blood pressure that moves blood through this system is left ventricular systole. Now, there's a mnemonic for learning the blood vessels on the right side of the heart and the left side of the heart. There's ramp. So there's the right coronary artery, which is the R. So that would be number 10 on your image, which branches to form the marginal artery. The marginal artery, the right coronary artery, provides blood to the right portions of the heart and the anterior wall of the right ventricle, as does the marginal artery. And that ultimately loops around and leads to the posterior interventricular artery, which provides the blood to the walls of both the right and the left ventricle posteriorly on the heart. The left coronary artery, on the other hand, branches, and this is the LAC, L-A-C, to form the anterior interventricular artery. The anterior interventricular artery is particularly susceptible to things like the formation of plaques and clots. And if you get a clot in there, it's going to essentially clamp off blood flow to the wall of the left ventricle, and that's going to put a lot of stress on the heart. And some people refer to the left anterior or the anterior interventricular artery or the descending artery as being the widowmaker, because so many people die from problems stemming directly from that artery. So you have your left coronary artery, which branches to form the anterior interventricular artery, which feeds the myocardial wall or the muscular wall of the left ventricle, and that loops around to form the circumflex artery, which forms the posterior, which feeds the posterior aspects of the muscular wall of the ventricle as well. So be able to recognize those and identify those on an exam and give me a general area, not a very specific, but a general area to which they're providing blood. Now, when you think about what can cause, some of the causes of a heart attack are, myocardial infarction is a major cause. And what is an infarction? An infarction is essentially a blood vessel that's occluded in which that plaque has ruptured and essentially clogged that blood vessel up. So what we're looking at here is this is the buildup of an arteriosclerotic plaque. So this is plaques in your heart, and you can have 80% occlusion and you can still be getting blood to a specific region of the heart. But if that plaque bursts and it triggers those mechanisms that can form a clot and it can stymie up blood flow, that's going to lead to what's called ischemia. So ischemia is when there's no blood flow going to a region. When you have this tissue in the heart, and in this case, particularly in the left ventricle, is going to start to die. And you can actually see that if this is running down the anterior interventricular artery, if this is where this plaque or this blockage has occurred. And this is what's called on an EKG a STEMI, an ST elevation myocardial infarction. So if we look at the actual EKG here, we can see our P wave, we can see our PR interval, our QRS complex, but look at the elevation of the S and the T. That is just a really pronounced sign that's very, very serious, because if somebody's suffering from a STEMI, that needs to be treated pretty quickly, either with clot busting agents or they need to go in and place a stent, because when a heart attack happens, right, if this ultimately leads to a situation in which the rhythm of the heart changes and that leads to a heart attack and cardiac arrest, depending on the amount of muscle that's damaged, the heart might be so weak afterward it can't do its job anymore, right? So some people don't die right from the acute cardiac event or the thing that happens directly. They die many days later as a consequence of the fact that a huge amount of their heart muscle is damaged. So if you see this on an EKG, that's a priority. And it can present STEMIs differently in men and women. Men tend to have what's called referred pain, meaning pain up and down the left arm, and angina pectoralis, which is essentially pain in the chest. women can have jaw pain and they can have nausea, and as a consequence of that, because we're traditionally taught to think about, a STEMI or an impending heart attack as being pain radiating up and down the left arm, sometimes women can be misdiagnosed. So it's important to read the current literature and to do the appropriate diagnostics. The mechanism behind an ST elevation, the reason that the T wave is elevated here is because in order for these cells to remain or to maintain resting membrane potential, they need to have the sodium-potassium pump working. If no blood is getting to that tissue, the sodium-potassium pump stops working. If the sodium-potassium pump stops working, the membrane potential of those cells goes up. When the membrane potential of those cells goes up, it changes the way that the EKG reads that. And at the end of the day, this is ultimately a consequence of activity in my favorite little guy, the sodium-potassium pump, and that's why you get that elevation. You don't need to know that on an exam. I'm just saying, hey, we use these blood vessels, and when you start to learn about them and learn about some of their diagnostics, it becomes really interesting. So we have our coronary arteries and our coronary or cardiac veins. The cardiac veins that you need to know are essentially the great cardiac vein, the middle cardiac vein, and the big daddy that leads back to the right atrium, which is the common drainage point for all the blood draining from the heart itself or the coronary circulation, which is the coronary sinus. So if you look at the posterior aspect of the heart, you can see, and what we are looking at here, by the way, this would be the anterior aspect of the heart because the apex is projecting to the left. This would be the posterior aspect. This is your middle cardiac vein. This is your great cardiac vein. This is the coronary sinus. And then anteriorly, you have your anterior cardiac veins. One of them we refer to as being the small cardiac vein. The big cardiac vein to remember is really the coronary sinus because that is the common point of drainage. So when we think about these, and again, because we're missing a lot of class and I'm trying to do this on the fly with no prep, no notes, no anything, I'm just trying to get you prepped over spring break, I am giving you some hints as to what types of models are used under what scenarios. So this is our coronary circulation model. If you look here, you can see the right coronary artery and the left coronary artery, the anterior interventricular artery and the circumflex artery very clearly. If you were to turn it around, you can see the other guys. You can see the great cardiac vein and the small cardiac vein very clearly. If you were able to turn it around, you could see the middle cardiac vein and the coronary sinus. Here again, we can see the arteries pretty clearly, particularly the anterior interventricular artery. And from the posterior aspect of the heart, we can see this middle cardiac vein and the coronary sinus very clearly. It might be worth your time to print these images, which I've taken myself, and therefore are non-copyrighted, and actually print them out and label them, right? Because what you're looking at is one of my labs. So I take pictures of all of these things, and it's these pictures that I have to use on the lab practicals, and you know how the practicals are set up. So it might be worth your time to do that. Now, if you think about your lecture handout, I've given you essentially this image, and I've asked you to label the blood vessels that you need to label. The first set of blood vessels we're going to go over are human arteries. And we're just going to go over them in the same order that your lab goes over them. So I'm on page 2 of your lab right now. And what I'm going to do is I'm going to use your lab as a jumping off point. Because if a blood vessel isn't on your lab, it's not going to be on the exam unless I specifically draw a focal emphasis to it. So if a blood vessel isn't on your lab, not going to be on the exam, either the lecture exam or the lab practical, unless I draw a specific focal emphasis to it. So this is just a comprehensive overview. One of the things I want you to really understand here is I want you to focus on the way that arteries are kind of structured. So let's say you get a black and white image on the exam, and it's pointing, there's a pointer here and a pointer here or a pointer here, wherever that pointer is. And it says, identify the blood vessel indicated by the pointer, or which of the following correctly identifies the blood vessel indicated by the pointer. And you come up to me and you can't say, I can't tell whether they're arteries or veins because it's black and white. That I am not going to answer for you, because when you look at the arteries, the system of arteries in our systemic circulation, it's coming out from the left ventricle, and the venous system does not have an aortic arch. So you can tell it's a system of arteries from the aortic arch, and then of course the three important branches off that aortic arch, which we're going to talk about in just a little bit. So we're going to go through essentially these blood vessels, these human arteries. You're going to label them on this image and answer any of the supplementary questions I've given you on your handout, which is now available online for you to print out independently. But we're going to go through these arteries, and we're going to go through them, and we're going to see how they're going to be presented on something like a lab practical as well. So one of my favorite questions on a lab practical says, human arteries, arteries near the heart. That's our next section. Human arteries, arteries near the heart. Here we have the ascending aorta. Here we have the aortic arch. If I ask you identify the vessel indicated by the pointer, that is the ascending aorta. It is not just the aorta. If I ask you to identify the vessel indicated by the pointer, that is the aortic arch. And one of my favorite things to ask about the aortic arch are the three branches coming off the aortic arch. It's like an A, B, C type question. You shouldn't need me to spell these out because they're in your lab. We have the first branch, which is the brachiocephalic trunk, which provides essentially the blood flow that goes to the head and upper appendage on the right side of the body. The left common carotid artery and the left subclavian. Brachiocephalic trunk, left common carotid, left subclavian. And then we get into our descending aorta. Now, the descending aorta can also be called the thoracic aorta when it's in the thoracic cavity. The moment that the aorta passes through a little opening within the diaphragm and it's now part of the abdominopelvic cavity, it's no longer called the thoracic aorta. It is referred to as. So we have our abdominal aorta the moment that it passes through the opening in the diaphragm into the abdominal cavity. The abdominal aorta, because it's subject to such high pressure fluctuations, especially in people who are genetically susceptible to defects in blood vessels, can actually create a situation in which the integrity of the blood vessel wall starts to become compromised and it can balloon out a bit. And that can produce something known as an abdominal aortic aneurysm. And the abdominal aorta, when the heart is in systole, when the heart's actually contracting and relaxing, can actually bulge and then recoil and then bulge and recoil, and you can actually see the beating of the heart through the abdominal wall. And that's not a good thing. That can indicate something very serious. So they'll often hook people up to like a at-home EKG if something like that is going on. And that's something that eventually needs to be surgically repaired, because if the abdominal aorta ruptures, that can be massively problematic. So the next blood vessels that we're going to look at are not the external head and neck arteries, because we're going to look at that with our special circulation, the external and internal head and neck arteries with our circle of Willis. What we're going to look at right now are the thoracic and abdominal arteries. So when you come down to this model right here, which is a great model, celiac means pertaining to anything in the abdominal cavity. And when you look at this first branch off of the abdominal aorta, that is called the celiac trunk. It's called the celiac trunk, so first branch off the abdominal aorta, because it branches to form the hepatic artery or common hepatic artery, which feeds the liver, the left gastric artery, which feeds the stomach, and the splenic artery, which actually feeds out to the spleen. So it's an extraordinarily important artery. And when you're looking at this, you'll see the celiac trunk, the common hepatic and the splenic, and the left gastric. So we've just gone over that. Then the next branch down, when you look at this next guy right here branching off the abdominal aorta is what's called the superior mesenteric. And it feeds the pancreas, small intestines, appendix, the regions of the large intestines. Again, I'm not going to ask you exactly what it feeds into, although there is a practice activity to help you kind of understand where these are oriented. But it's important to kind of realize that. So this is a really good model to ask about the celiac trunk because you can actually see the three branches in the superior mesenteric. This is also a good model. I don't typically ask about the celiac trunk on this model, which is our blood vessel man model, but I will ask about the hepatic artery, the left gastric artery, and the splenic artery on this model. So it might be worth the time to go through and label those as we go through our different abdominal models. Now, when we look at this abdominal model and we're looking at all of the blood vessels we need to know, we have our celiac trunk, which branches to form the hepatic artery, the splenic artery, and the gastric or left gastric artery, which feeds the liver, the spleen, and the stomach, portions of the stomach. Our superior mesenteric, which we talked about, feeds a huge amount of the GI tract. And as we continue going down here, this model I will ask about those two things on. I don't really like the way that the inferior mesenteric is emphasized on this particular model. So we're going to use a different model to ask about the inferior mesenteric, and we're going to kind of jump back and forth. This model is the one that I like to ask about the inferior mesenteric on. So we have the celiac trunk, which branches to form the hepatic artery, the left gastric artery, and the splenic artery, and those are just cut off, but this is the first major branch off the abdominal aorta is the celiac trunk. Really, really important. That's the superior mesenteric artery, and then this is the inferior mesenteric artery, and as you're going through your handout and doing your practice, think about what it is that the inferior mesenteric artery feeds into. Make sure to put artery after your answer. Projecting off of the abdominal aorta and going into the pelvic cavity or the gonadal arteries, from the name I'm sure you can kind of put together where the blood flow is going from there, or what those arteries are feeding. Notice that I use the term feed when I'm talking about a system of arteries. If I ask you into which blood vessel does this blood vessel feed, I'm saying in which blood vessel going away from the heart, where's the next blood vessel? We either have a branching point or something like that that's going to dictate where our next blood vessel is, or a shift in the position of the body. If you continue going down, so we have the abdominal aorta, branching off of that are the celiac trunk, the superior and inferior mesenteric arteries, the gonadal arteries. Then you have your renal arteries, which feed your kidneys, and branching off the renal arteries, this very kind of subtle little branch off there, is the suprarenal artery, which feeds into the adrenal glands that sit on top of the kidneys. As we continue going down here and we get this first branch of the abdominal aorta as it branches into the blood vessels that are going to feed the lower limbs, this is what's called the common iliac artery. So this first branch is called the common iliac artery. So identify the blood vessel indicated by the pointer. It's the common iliac artery. The common iliac artery then branches to form the internal and external iliac arteries, which run essentially kind of within the iliac region that's created by the iliac regions of the coxal bone. So as we continue going down here, this is going to wiggle out a little canal, and eventually this is going to become the femoral artery when it's in the femoral area of the body. This is a closed system, so it's all one tube that branches or changes its position in the body, and that's how we name these arteries or these blood vessels, right? But it's important to be a little bit precise with where you're describing a blood vessel to be, because there's a lot of problems that can crop up that you need precise information as to the position of a blood vessel. So we've talked about that. Now, when we look at this, we have upper limb arteries and lower limb arteries. The first of the arteries that we're going to look at are the upper limb arteries. So a model like this would be great for upper limb. Here we have the subclavian artery. The subclavian artery runs deep to the clavicle. It feeds into the axillary artery, which runs through the region of your body you associate with being the armpit. That feeds into the brachial artery. The brachial artery is what we clamp shut when we're doing blood pressure, and the pressure we're looking at when we take blood pressure. The brachial artery branches to form the radial artery, and you notice that it's running along the radius, which is on the thumb side when the arm is in anatomical position, even though this model deviates a bit from anatomical position. And the ulnar artery, these lead to the superficial and deep palmar arches, And with respect to, you see on your handout it says trace a drop of blood. If I asked you to trace a drop of blood from the left ventricle to the right hand back to the right atrium, what I'm really asking you to do is go, okay, that blood's going to go through the ascending aorta, through the brachiocephalic trunk, to the subclavian artery, to the axillary artery, to either the radial or the ulnar artery, to the superficial deep palmar arches, to the digital arteries, where they'll branch to form into arterioles. From arterioles, we'll get capillaries. Capillaries are the point of exchange, and we've already talked about that in great detail. And then you're going to have your venous return of blood back to the heart. So just kind of keep that in mind, because we're just going over every one of these major blood vessels, and we're saying, hey, look at the arteries that you need to know. And it looks like you only need to know your axillary, your brachial, and your radial with respect to the upper limb. So there you go. But make sure to give me those arterioles and the capillaries, because I want to know how the system turns around and where the point of exchange in the system is. After that, we have our lower limb arteries, and this is a great model to show lower limb arteries. So we have the common iliac artery, the internal and external iliac arteries. External iliac artery turns into the femoral artery, which loops around behind the back of the knee. When that artery is in the region behind the back of the knee, forming that kind of network right there, it's called the popliteal artery, named after the region of the body. That branches to form the anterior tibial artery and the posterior tibial artery. And the final artery you need to know is the dorsalis pedis artery, which sits on the dorsal aspect of the foot, feeding the tissues in that region of the body. So that's just me going through this and me giving you specific kind of close-ups on what I could ask. So it might be worth your time to physically print these out and label these things. Now, if I ask you to take blood somewhere, I'm also going to ask you to bring it back. So after the arteries branch and form into very small blood vessels called arterioles, they feed into capillaries. Capillaries are the point of exchange. Capillaries are then drained by venules, and then that blood is brought back to the heart by veins. Veins aren't always blue, but in systemic circulation, they're always going to be blue, which indicates oxygen poor or deoxygenated blood. So when you look at the veins that are close to the heart, because that's the way it's organized within your lab, you have the brachiocephalic veins, which are draining blood, of course, from the upper appendage and the head. And those ultimately form a common point of drainage into the superior vena cava. If I said, into which blood vessel does this blood vessel not feed, which is going away from the heart, but drain, which is coming back to the heart, that would be the superior vena cava. If I ask you about the superior vena cava, it's probably going to be on the heart model. If I ask you about the inferior vena cava, I really like this model because it shows you that the inferior vena cava is huge and it parallels the abdominal aorta, and it has the same types of branches to form veins that we also need to know. So as we go through, the external head and neck veins I'm going to get to again when I talk about that different part, or when we get into our special circulations. So we have our upper limb veins, and the ones that you need to know are your ulnar and your radial vein. This here is the median antecubital or median cubital vein. There are 3 veins that run through the arm because veins are more abundant than arteries. The one that's closest to the head is called the cephalic vein. The one that's been cut away here that would run right kind of through the brachial region is the brachial vein. And the one that runs right here is called the basilic vein. Eventually, those will feed into the axillary vein, to the subclavian vein, to the brachiocephalic vein, and then back into the superior vena cava, which will return that oxygen-poor, nutrient-depleted blood back to the right side of the heart, which is going to pump your pulmonary circulation again. Again, think of these models and think about how I'm using them. Now, when you think of the external head and neck veins, this is a really interesting one. So we have our left subclavian vein and our right subclavian vein. The clavicle sits right above them, is why they're called subclavian. And this is your jugular vein, which is draining blood essentially from the external and internal regions of the head. So from the circulation that feeds into the brain and the external regions of the head that feed like your glands, salivary glands, and other things, muscles, etc. This is a really weird fusion point. So here we're looking at a cadaver, and this is the internal jugular vein and the external jugular vein, which both branch off of the subclavian vein. In this case, we have a common jugular vein, which is branching to form the external and internal jugular vein. But I've looked at this on a cadaver. I've never actually seen a branching pattern in which the bifurcation is that close to the head itself. So when we're looking at this, and that's the sternocleidomastoid muscle, so we're looking essentially in this region right here. It's just showing us that there's anatomical variation. That's the only point I'm really trying to get at. So when we continue to look here, we have our ulnar, our radial and our ulnar vein. The median antecubital vein, which is really important because that's where you draw blood from, and then we've talked about this, the basilic, the cephalic, and the brachial veins, which lead into the axillary vein, all of them to the subclavian vein, to the brachiocephalic vein, and then back to the right side of the heart. If I ask you to trace a drop of blood from the left ventricle back to the right atrium, let's play a little game of practice right now. From the left ventricle, a drop of blood is going to move to the ascending aorta, and if I say to the right hand or the left hand, right, which is going to be different because if it's moving to the left hand, it's not going to go through the brachiocephalic trunk. It's going to go through the brachiocephalic trunk if we're talking about the right hand, your patient's right. Brachiocephalic trunk to the subclavian artery, to the axillary artery, to the brachial artery, to either the radial or ulnar arteries, to the arterioles and the capillary networks of the hand. You're going to get exchange, and then venules are going to drain that blood. It's going to bring it back to veins, either the ulnar or the radial veins, to the antecubital vein to you pick your one of these three because that drop of blood can take whatever pathway it wants, so it could go through the basilic, the brachial, or the cephalic vein, to the subclavian vein, to the brachiocephalic vein, to the superior vena cava, back to the right side of the heart. So that's what I'm really asking you to do with tracing a drop of blood. It forces you to know all the blood vessels in that particular region. If we're talking about veins in the lower limbs, so there are a few veins within the lower limbs you need to know, and then I'm going to go back and I'm just going to highlight some of the veins that we haven't talked about. Some of them are going to be discussed within the special circulation. If I asked you to trace a drop of blood from the left ventricle to the, let's say, right leg, for example, it's going to go from the left ventricle to the ascending aorta, to the aortic arch, to the thoracic aorta, to the abdominal aorta, and then to the right common iliac artery, to the right external iliac artery, to the right femoral artery, either to the popliteal artery or popliteal artery, either to the anterior tibial or posterior tibial artery, to the dorsalis pedis artery, where it's going to eventually branch to form arterioles. Arterioles are going to feed capillaries. Capillaries are the point of exchange and turnaround. Once you get that exchange and turnaround, there's a great vein to bring you back here. The longest vein in the human body is one that runs along the lateral aspect, posterolateral aspect of the thigh, and that is referred to, the leg and the thigh, and that is referred to as the great saphenous vein. It's a huge vein, and because it's so long, it's the one that's most likely to form serious varicoses because the valves fail because there's so much gravity pulling against it, especially if you're not mobile or you have a genetic predisposition to that. So that great saphenous vein can bring you all the way back up here, essentially, to the external iliac, to the common iliac, and then to the inferior vena cava, which is going to take you back to the right atrium of the heart, right? So with respect to the veins you need to know, you have the femoral vein, and then the vein running behind the knee is the popliteal vein. And those are the only veins that's really making you know for the lower limb veins. Now, a couple of blood vessels or veins we didn't talk about in this region, but are kind of intuitive. We have the renal veins, which drain blood, of course, from the kidneys. And then when you look at this, let's see, are there any others that we need to know? No, we're going to talk about those in conjunction with when we talk about, there we are. We're going to talk about a lot of these veins in special circulation, but here are your gonadal veins. So just like you have your gonadal arteries, you have to bring blood to those regions of the body. Here are your gonadal veins right here. So there we are. Now, things that I want you to take away. Of course, do your handout. Label the images I provided on both the PowerPoints that I've made specifically for you over this break and on your lecture handout, because it's going to be in your best interest to do those for the quiz and for the lecture exam. And think about tracing a drop of blood. Actually practice tracing a drop of blood to the hand and back to the heart, or to the foot and back to the heart, because it gives me an idea that you're pretty familiar with the blood vessel networks that feed back and forth. With that said, I haven't showered because I've been doing this for about 5 hours. So when you say, I don't really feel like studying, Matt, I don't really care, because I have to sit here and do this too because the campus is closed. It's created more work for me. So there you go. Great mood. Your instructor is just A+ right now, and I love you guys very much. All right. Bye-bye.